everybody. This is Nina Crowley, Seeka's Professional Affiliations and Education Manager, and I'm excited to be here today with Nowreen Haq, a doctor who is triple boarded in internal medicine, obesity medicine, and endocrinology, and she specializes in transgender endocrinology, which is why I wanted her to come on here and talk to us today, because she's got such a wealth of information. And I know when we met back at the obesity medicine meeting, the second time you and I were giving talks at the exact same time. So I know I missed that one, and I was hoping you could, share with us today some of the information that you shared at the meeting and talk to us about your specialty. In body composition, this comes up. We get questions about this a lot. And so I know when we started talking, we started to unpack a lot more. And I think our listeners would want to hear about that. So thank you.
Wonderful. Thank you so much, Nina. Thank you so much for inviting me. And I think, it's a much needed field to to intervene and talk upon and really brainstorm of where in phase of gender affirmation therapy, what do we see? How do we see the transformation of the muscle mass, the fat mass, and how do we really interpret this? So I think it's an open question and a field that we are still investigating, but I was actually going to share with the audience that for obesity management in in patients while they're going to gender affirmation is not one specific medication that fits for all, because it had been a challenge to see how even GLP-1 receptor agonist works and what dose it works and how is it going to change the lipid profile, how is it going to change in and is it going to be different once you are really having the right level of testosterone in a transgender male patient, which would be actually affecting your lipoprotein particles and your lipid profiles in to begin with. Not only that, to think about the cardiovascular outcomes in terms of hypertension management. So there's so many points and dots to connect, when you're starting gender affirmation therapy. That's one. And secondly, when you're trying to titrate the gender affirmation therapy, the obesity becomes almost like a constant parameter, and the others are kind of a moving parameter around it. And we have to be really putting a lot of flexibility and putting a lot of algorithm and protocols to really reach the right BMI or right actual weight for each individual patient. So I think this is where we have to really treat the patients with acumen and precision medicine an idea, because not all bodies would react the same way with the gender affirmation therapy, right? So you can see the fluctuation in the hormones, and typically when I'm checking my patients in once every 3 months, I'm seeing so much of fluctuation in the either in the estradiol level or in the testosterone level, and to plot it against the lipoprotein particle, the abdominal obesity, it is something very intriguing, scientific, but yet really not really that touched upon. So I appreciate talking about this very scientific field, which has many promises and many opportunities to offer, but we have to kind of break the mindset of one dose, one size, and that fits all.
It's a very clear example of how it's not one size fits all, and it's not just two categories. And I think that's what I'd really like to sort of step back and do, actually, is just maybe have you educate us a little bit about, what the process is and how that might impact the body composition in your patients, and then kind of maybe get to a little bit more about how the changes happen and maybe a timeline, because I know there, it's not going to happen at the same time for each patient, and how does that typically go? Can you give us a...
For any gender affirmation therapy, what we have pretty much noticed is what changes first. So the muscle mass, the abdominal obesity, or the fat distribution, should I say, the subcutaneous fat distribution, the visceral obesity, change, or the visceral fat distribution, that changes in transgender males undergoing the gender affirmation therapy with testosterone typically, and I should give a range. Typically, we see the change 6 months to up to a year or even more. But 6 months might be a good parameter to think, okay, that's where we are going to see the change in the composition. We are going to have really, and when I'm talking about gender affirmation therapy, the dose of testosterone is obviously much more than than you're doing a testosterone replacement in a hypogonad male. So we have to consider that as a factor as well. So when we are seeing the change in the body composition, I think it would be reasonable to say that 6 months onward would be like in our time frame to first note the change, and then we have to really plot the lipid profile, plot the abdominal obesity or the fat distribution, subcutaneous and visceral, based on each patient's testosterone levels and so forth. So it's a I know it's complicated, and I don't know if I have answered. I wish I could give you a more clear answer about the dosing, exact parameter, but it's so precise to each body's metabolic need and the make, that I think it would be a wonderful area to to look upon and look more into impedance techniques to to help us aid and plot this this composition as we go along.
I think it would be interesting to see, even, in a study, more like frequent measurements during those 6 months to see how those are changing. So I'm assuming you're seeing decreases in muscle mass and increases in adiposity, or flip-flopping, depending on the patient. But almost, instead of, my initial thought or question was about which group do we compare the patient to as their normal reference group, because it might be different than their stated biology. But now I'm almost thinking it might be more interesting to just sort of look at an individual patient about how those numbers are changing as they're going through that time period. And then, at, a year or 2 years, are they of the new gender's body composition norms, or are they somewhere in between?
Excellent question. So I think you really cannot compare it to a normal male control or a normal female control, right? Because this is where a patient can be a comparison of his or her own. So in other words, this is exactly where we have to practice precision medicine at its best to see what exact cardiometabolic profile is safer and best for that particular patient, and what BMI, what composition would be ideal, and how the individual patient would reach that cardiometabolic profile, rather than it's in other words, it's not a T-score index where you're comparing it with the general population. So I think that's where a precision that's where the bioimpedance technique comes really very help as a helpful tool to to look into because again, each person's metabolic journey would be different, right? And the levels of hormone stabilization would be different. 6 months is probably a very crude estimate of each each body transformation time. But then again, the fluctuations are so different for each patient, right? So I think it would be wise to say that we need to have a set parameter, set goal for transgender obesity management, and each patient should actually have their own precision goal in their own pace, and a periodic monitoring and adjustment of medication as we go along. By medication, I mean it can be the glucagon-like peptide receptor agonist. It can be depending on what other cardiometabolic risk factors there are, right? Whether there is type 2 diabetes, can we think about dual agonist when we are moving on from monoagonist? All those parameters and all those medications are in place, but we have to again make sure that this is exactly what is going to fit with the new, or with the stabilizing hormone level as we speak. So so for transgender females, it should be the estradiol level that's going to dictate us. For transgender males, it's going to be the testosterone level that's going to dictate us.
So do you time obesity medications in that process? Is there any guidance, or how do you decide when you would start someone, or if they were on that before, would they come off of that? Is there any, how does that kind of discussion work, or is that also pretty individualized?
I have had patients who had already been on GLP agonist for their type 2 diabetes when the gender affirmation therapy was actually taking place. So if the patient is already on therapy, I do not take them away from from a medication that's therapeutic for for the diabetic population, right? Or even pre-diabetic population, to so to speak. So to answer your question, Nina, I think it depends on about initiation of GLP-1 and the dosing. It all depends on the changing parameters, the body weight, the cardiometabolic profile, and also like the tolerance
Mm.
of the GLP agonist. There is no specific guideline for transgender patient population per se. So we are pretty much following the same standard guideline as we are starting in any patient. Like for example, we are starting at 0.25 of semaglutide, Ozempic, and then we're moving up as the body tolerates. So I'm not practicing anything different in my transgender patient population, so to say. But again, what the point, the gap I think we need to feel is where is the body composition change, and how is that going to help us change the dose of the GLP agonist, based on body composition, not only based on body's tolerance to the medication. So I think GLP agonist and bioimpedance together can have many scopes of giving really a very therapeutic medication dose, then to wait upon patients tolerance and then going up on the on the medication. In this era of precision medicine, I think it's a great opportunity to practice more objectively rather than subjectively.
So do you use bioimpedance now in your practice, and at what time points, or is it every visit? And I'd be curious too to just see how you see changes, whether that be raw data values, like increase in
Um,
5 or 10 pounds of muscle mass, or what are we talking as far as a change values?
so I have used in two patients so far. The usage of bioimpedance technique. I wish I could have more patients on bioimpedance, using bioimpedance tool. Unfortunately, I think coverage always comes in the way, and
Mhm.
the availability, coverage, and patients access, all those are kind of limiting factors at this point, investigated it as we go along. But the question was more so about the change. I would say that the two patients I have examples of had really shown the changes over over a period of 6 months. That's why I think an anecdotally I was telling you about 6 months, but
Mhm.
also supported by some evidence of of publications that I can share with you. That that this would be a good 6 months might be good benchmark time to see whether there is a change. So maybe ideally, if I were to set up the algorithm, which I'm actually doing in my practice, to have a baseline, and then to to have every 6 months to see how this has changed. And if not, if the distribution of adipose tissue did not change, can we have that as an objective measure to increase the GLP agonist, or obesity medication in general, to see if that is going to really meaningfully change the fat distribution along with the gender affirming therapy, if that
Mm.
makes sense.
It does, yeah. It's definitely complicated, and
Very complicated.
glad that we have experts like you in this area, because it's you're tying together some different fields, right? The endocrinology piece, the weight management piece, and then just what's happening, as a result of the hormones in the individual. So what so it sounds like in a ideal practice, that's sort of what you described. And how um what other types of measurement tools are you thinking that you would use in an ideal situation, or in your clinic? I don't know how many kind of patients you're seeing on an average basis, but tell me a little bit
um
about that.
Sure. I do have cisgender and transgender patients, right? So, I do have patients with diabetes and without diabetes. I do have patients with, obesity, um, awaiting bariatric surgery or post-bariatric surgery. So I do have a wide spectrum. I have patients with hypothalamic obesity, both acquired and some genetic linked obesity. So it's an interesting, spectrum how obesity comes in different phases, right? So I think the more we are getting a deeper dive in obesity management, we are learning more and more of how each each patient with obesity can be really treated differently than the other, and even in the same family.
Absolutely.
So to answer your question, I think the tools that we can use right at this point, what are the tools we have in our hand? Definitely impedance technique is a huge huge help in getting the idea of distribution of each individual's body, the subcutaneous as well as the the overall the skeletal mass. But another thing we don't use so much but I think can be very helpful is visceral obesity kind of objective tool, something like a maybe like a fibroscan, something that can help you to understand the hepatic fat distribution. Because I think a lot of the patients, at least in the transgender obesity parameter, would actually have we are looking into the NASH aspect, we are looking into the non-alcoholic fatty liver disease aspect, and of course both estradiol and testosterone are known to have the hepatic metabolic pathway influence in many different ways. I know we have limited time. Perhaps we can get another session to talk about just from the hepatic metabolic perspective on gender affirming therapy. But to start with, I think it would be helpful. It's not there yet. We don't use fibroscan. I have probably sent few patients out to get MRI of the liver, but very very few times. If I were to add an objective tool along with the bioimpedance technique, that would have been hepatic visceral or visceral obesity scanner.
Great. Yeah, that's super interesting. So I think it sounds like more to come from a technology standpoint as well.
Yes.
Yeah. Well, great. I mean, this has been super helpful to understand, and I think a niche area that is becoming um, less niche as more and more people are having this. So thank you for being a resource, and I look forward to getting you all those tools in your clinic too, so that you can do what you do best and put some evidence out there so that other people kind of know what best practices are as well.
Great. Thank you.
Yeah, anything that we didn't cover that you wanted to say before we end?
I think of course this is just a primer. I'm hoping that I can come back again in a couple years from now with more objective data. But this was a platform where I could share what is an opportunity. I would say it is a challenge, but it is also an opportunity to to look into the metabolic platform in a more objective manner and in a more precise manner. So thank you for having me today. Appreciated your time.
Thank you. Yeah, and we'll link to some of those articles so that we can do more reading on that, and hopefully have more conversations with others who are doing this work as well.
Excellent. Thank you so
Right.
much.
Thank you.